Our final speaker is Mary Politi. She is a professor of public health sciences in the Department of Surgery at Washington University School of Medicine. And Dr. Politi also directs the Center for Collaborative Care Decisions.
Hi, thank you to everyone for your wonderful talks. It's a little intimidating to go last, so I hope that this integrates some of what we've discussed throughout the day. I'll be talking about tools and processes to support decisions and enhance risk communications with patients. Here are my disclosures, most of which are grants. I wanted to start by talking about evidence-based medicine because when I first started looking into how we communicate risk, people thought, why do you go to evidence-based medicine? That's something we know. That's something we decide we're going to do. But in fact, some of the steps in evidence-based medicine start with uncertainty. They start with translating uncertainty into a question we want to answer for a given patient, and then retrieving the best evidence available and appraising that to answer a question and apply these results to individuals in the room. Because it really starts with these estimates at the population level, and then we're trying to use this population data to inform clinical decisions for a person, a single person. And when we talk about risk to patients, a lot of people have not yet thought about this in the context of health. They think that something's either going to happen to them or it's not going to happen to them. And they come and ask, well, what do you think I should do? And when you think about it in terms of the weather, people often blame weather forecasts for being right or wrong, when really they're forecasts, they're risk, they're predictions, but we can't say for certain what's going to happen. So a lot of people think my chance of something happening is 50-50. It's either going to happen or not. So it's really on us to try to do better to explain what we mean by these probabilistic uncertainties. But clinicians often struggle with this as well. If you haven't read anything by Paul Hahn and his work on uncertainty management, please read his work. He's such a brilliant thinker in this space. This is one of his more recent papers where he talks about clinicians in qualitative interviews that told him how they manage uncertainty with their patients. And on the left side, people talked about trying to cure or reduce the uncertainty by seeking out diagnostic information, consulting with colleagues, going into the literature. And on the right side, they tried to seek comfort through it and deal with it and manage it through sharing it with patients or sharing it with colleagues. And in the middle, there were emotional and cognitive responses. So I'm going to talk a little bit about how we share it with patients when we know it's there and we can't reduce it because someone's in the room and needs to be treated. So this is a great quote from one of his clinicians in his study. I underestimated, maybe was a bit naive in thinking that clinical practice would have these relevant definitive areas of black and white and very statistically quantitative processes. The more I got into it, the more I realized there's more gray, and that even when we try to quantify things, they're not always as certain as we would think. It's helped me shift more from the science to the art. Where we aren't certain, we give the patient information, help them make their choice, and make it more of a personalized element. Part of you wants to get rid of uncertainty, like, well, let's get to a better equation. But another part of me says you kind of have to embrace it. So through shared decision-making, this is a part of embracing this uncertainty and managing it with patients. Clinicians start by acknowledging that they're a team working together with patients or families, and then communicate these alternatives through these risk prediction models, through these diagnostic predictions. And then they can come up to talk about how the patient values those possible outcomes of options and come to a decision. So this is my quick and dirty summary of risk communication research, but there's a whole bunch of research you can look into to get more detail. We have to use numbers. A lot of people think when there's uncertainty, we should use words to talk about high, medium, or low. But without numbers, people will underestimate their risk and overestimate their benefit from something that might happen. We have to use a number that makes sense to people. We can't use 1 in 10, 1 in 12, 1 in 20. People can't compare that easily. Keeping the same denominator makes it more transparent and clear, and especially if we can use a visual to supplement. Pictures do speak to patients. They can visually and quickly look at it and see what's bigger or smaller. And I'll show some examples of this on the next slides. We need to keep the denominator constant, and we need to provide a reference group. I saw this in some of the slides for clinicians today, but we forget about this with patients. Who was studied in this population level data? Was it someone like me, or was it someone that may not be like me? What was the time period? And what does this really mean? And we often say, this new cancer drug is going to reduce your risk by 50%, but it might reduce their risk by 2 in 1,000 to 1 in 1,000. So that means something very different to someone trying to make a decision in the room. So here's an example of a melanoma risk prediction tool that's used with patients. It's clinical decision support, so it's designed for the clinician, not for the patient, but to use together to predict someone's risk of metastases, so whether or not the patient will need a sentinel node biopsy. And this is now recommended for use, publicly available, developed in Australia, where they're doing a lot of melanoma research. But you can actually get a specific personalized risk for a patient, talk to them about what their risk means, and then talk about whether it's recommended or not, or if there's a shared decision to be made because they're in the gray area of whether or not a sentinel node biopsy is recommended. This is from a decision tool that I've developed with colleagues about breast reconstruction after mastectomy, where patients can actually go through education about breast reconstruction, quality of life-based decision, not needed for cancer, but can help people feel better about their body after a mastectomy. But there's a very high risk of complications, and it's much higher depending on patients' risk factors. So this data pulls from the EHR, in our case it's EPIC, and it gets all of their risk data and populates this model automatically for the patient, and then compares them to a reference group of someone with no risk factors. So they can see how much their risk factors that they have, in this case, it goes from 7 out of 100 to 15 out of 100. So on the same graph, reference group, icon array, and frequency out of 100. And the patients can then use this with their clinician because the clinician also gets a summary. Another story is if they actually open the summary, but that's for a different talk. And then this is outside of the cancer context, but I love this because we've talked a lot about patient portals and patients getting information on, say, a Friday night when you can't even be paged or contacted, and they get this information in their chart. This is developed in the context of diabetes, and there's often a lot of out-of-range lab results that are flagged. Brian Zickman-Fisher and colleagues at Michigan have looked into how we can do this better by providing a reference group. How does the patient know when to worry or not to worry? So this is an example studied in several trials where they found that having a reference group or a goal range for people with type 2 diabetes really helped them interpret their out-of-range results. And then they knew whether to worry or not worry, whether to change behavior or to talk to their clinician, because some of these results were flagged and they were expected to be flagged because they were being compared to someone without diabetes. So this gave them their result, their goal range, and then one of them also gave how the other ranges might compare in terms of value labels. And a lot of people say, well, we're doing this all on the tool. Should we prepare patients before a visit through the portal or through other means, or should we do it during the consultation, working with a clinician to talk about what this means? And it really depends. Some people love conversation aids for a clinical conversation because it's easy for the patient to read and go through quickly in the office. Some people alluded to this, I think, in the Oracle talk before. Computers are not all designed to work seamlessly in the workflow. And so we have lots of clinicians who tell us, I prefer paper, because the computers in the exam rooms take forever to load. They log in, then they freeze, and then I have to unfreeze it. It breaks up the workflow. So until we solve this technology problem, there are lots of people who are going to say, give it to me on paper. I'll talk to the patient that way. And then other people say, I don't mind digital tools, but I want people to do it after the visit so they have time to let all of this risk data sink in. Let's say someone just gets a diagnosis of cancer. They may not be ready to have this more in-depth conversation about pros and cons of options and all of this detail. They just need to process. So having a digital tool for someone to review the information either before or after the visit really helps. And then I firmly believe in this also for level setting. We have a lot of people tell us that they don't like to talk about risk with patients because it's something that may go wrong. And it's much easier to talk about the positive things that can happen. So this is also part of people overestimating benefit. It's also clinicians that have some hesitation to address something that could go wrong. And they'll say, I don't really like to tell them about that. I know I have to, but it's not easy, it's not comfortable. So if we have a tool, we can create the language, we can use softer language, but be transparent and clear with patients. And I just want to end with the fact that precision communication and shared decision-making is not new. Hopefully, our implementation science has gotten better than this, but we know it lags behind. This is a quote from 1892 where someone said, it's much more important to know what sort of patient has a disease than what sort of disease a patient has. And I think that's the essence of all this precision communication. So, thank you.